we go towards a tipping point in medicine and also in surgery, because within few years, the majority of your patients will be elderly people if they already not are the majority. So that's why I'm standing here, and I'll try to take you a bit along this road, along this trip in good medicine, good surgery for, let's say, the silver tsunami which is facing us. The silver tsunami, which is bringing us all kind of good things. And as already said, our mission is to guide people, to guide elderly people, frail elderly people, but also clinicians and students in this exciting landscape. Now, before starting off, I would like to know, as I'm thinking many of you are surgeons, who is able, in fact, who would be able to assess frailty in your patient in a formal way before surgery? Please put up your hands. Who's able to assess frailty? So, oh, that's only Harry, but he's going professor, so there's still something to learn, and that's my mission for today. And maybe that's even the moment, because I'm very much in fond of this, this tapestry, that I can also take place in surgical education talks to guide you a bit towards frailty, how to recognize this, and why is it important to recognize frailty. So here, the silver tsunami, which is in fact also giving you good news, because there are some surgeons who are looking for jobs. Well, they just have to wait. Just wait. There's the expectation in 2020 that there will be a shortage, at least in the United States, of general surgeons, of vascular surgeons. And this is all because of the aged population that requires a lot of investigations, but also, of course, surgical therapies. So that's the good thing. That's the good thing. But when you really want to give added value to this population, you still have to know more about them. It's not just surgery that you have to do. That's the thing to learn. That's the thing where education comes in. So what is this about? Why is this the tsunami? Well, here you can see, as Harry is very much involved in abdominal surgery, I looked up for some data, and here you can see the data of the admissions on colon and rectal cancer expected to be in the Netherlands. And here you can see 2020. And here in 2020, 80% of these people will be elderly. And that's even without the coming screening on abdominal cancer. So the majority will be elderly people, and there will be all kinds of questions when, how to operate these patients. So that's where geriatrics may have added value. Now, what could be this added value? And here I would like to just very shortly, very briefly state the case. And I was a bit hesitating whether or not to tell you this case. It's a bit slipping off and on, I think, the microphone. As I told, I was a bit hesitating towards this case because it's a special case for me. It's my mother. And I also phoned her. I asked whether, is it all right that I present you some part of the story, and she agreed. For the sake of education, she was fine for me doing so. And I was very much... No problem. Oh, it is a problem. Special assistant. Very nice. And let's do it together. It's as it should be, surgeons and geriatricians making good things together. So, no, my mom had an impressive affair not so long ago even. And she's 90 years old now. And what happened, she was known with an abdominal aneurysm. She was known for it with the GP, the general practitioners knew. And on an afternoon, she had, in fact, abdominal pain. And she went to the clinician, to the GP, and asked, well, what could be there? And he was thinking about her abdominal aneurysm and got anxious. So he sent her to hospital with the message, she's known for an abdominal aneurysm, please do some imaging and check for this, because I'm not very confident about it. So she went there, and there was already a small alarm over there that somebody would be coming with an abdominal aneurysm, maybe bleeding. So she got an ultrasonic investigation, and she was not very gently investigated. She got more pain during the investigation. And the one who did it was alarmed and was not so much experienced and thought she saw the bleeding, in fact. So she alarmed the surgeon and said, well, I've got a bleeding aneurysm, come immediately. And he thought, well, this is just a small hospital, we can't do this here. So I alarm the hospital 20 kilometers nearby that there will be an acute abdominal aneurysm coming over immediately. So he only looked at her for just a second, no laboratory investigations, nothing, but in fact he immediately sent her to the hospital. So my mom and my father also, my father's 92 years old, were taken in the ambulance to this hospital, big hospital, where everything in fact was already ready to get her into the surgical theater. So you can imagine what kind of stress was in fact there. And one of the important things in fact was that my mom already agreed with the GP that she would not want to have big surgery or big investigations anymore. So there was a big problem to my mind, after hearing this afterwards, that she was transferred for an emergency investigation, while the surgeons in fact were not sure and were just taking precautions for if there might be the necessity of surgery. To make a long story short, there was nothing wrong. She did not have a bleeding, and she's still, in fact, living happily with my father. But they had an enormous stress. And my father also had an enormous stress, and they could not imagine what went wrong. So this is just a short story about what, in fact, comorbidity, what atypical presentation of diseases can do in emergency cases for surgeons. And these are just three of the principal things of geriatrics. That presentations of acute diseases come in an atypical way. It's not the typical case of abdominal pain or pain in your back that announces the bleeding of an aneurysm. And that's very crucial to be aware on every emergency ward, on every surgical ward. And it's also comorbidity and frailty that should, in fact, be one of the basic instruments to assess. And last but not least, it's the outcomes that are different. It's not just about, let's say, survival. It's much more about quality of life, and it's also about what have people already decided to do or not to do. She did not want, in fact, surgery anymore. And that's what we should realize and what we also should take into practice. This is about surgical education. These are the fundamentals that should be brought into the theater, and it's in fact also linked to what Kees already told. We go towards a scenery in disruptive innovation, a lot of disruptive innovation, and that's also heading towards surgery. But it's in fact the patient times this innovation which really predicts the risk and the benefit. And when you look at elderly people, such as I would announce Mrs. Fransen. Mrs. Fransen stands for me for every typical 80-year-old patient that we should be aware of. And this Mrs. Fransen of 80 years old is in fact having 40% risk, 40% chance of being in a high risk group when she's 80 years. And these are the data from a big surgical survey in the UK in which they concluded that the risks in surgery were mainly, in fact, determined by the junior staff, which had to take care of the most complex patients, which are the geriatric patients. So surgical risk should be in the case. And this is Mrs. Fransen, as I told you. Mrs. Fransen, in fact, should be the hallmark of all our innovations. When there's an innovation, she should also be able to benefit of it. Otherwise, the silver tsunami will not be helped very well. You will not realize always your added value. And what is she having? What's her problem? Well, she's married, that's not a problem. She loves her husband. She has mild cognitive impairment, so no dementia. She is using a walking aid, and she has diagnosis of heart failure and colonic cancer. So she is having surgical medical problems. But what to do with it? That's an important question. How to help her and how to assess her in the right guideline, in the right treatment. So there's an urgency to do it better in these cases. And for the Netherlands, we had a survey of the NIVEL, which is in fact the research institute of primary care, and they assessed the hospitals, and they found out that every year 2,000 people in Dutch hospitals are dying while it would be avoidable. And there's a big safety program now going on because of these data. But they also had alarming figures about surgery. Most of the adverse events in this cohort were caused by surgical procedures. And most of them, or a third of them, would be avoidable and are happening in elderly people. So these alarming figures, in fact, cause my statement that geriatric education should be an obligatory part in surgical training. So here, again, Mrs. Fransen. And she is married, as I told you, she's married to Mr. Fransen, and are they both frail? Who's frail? Is she really frail, despite her comorbidity? That's a big question. For me, it's a big question. For you, not so far. But why? Why isn't it still a question for you? Because there are data coming on and presented in your journals that present a very important fact of frailty. And here you see a recent study in the Annals of Surgical Oncology about an 80-year-old cohort of 12,000 people, and they looked at the predictors of survival the first year. And the most important predictor here is frailty for death in this cohort. So frailty as a variable, as a characteristic of this patient group is a very important predictor also in surgery. So that's where it's all about. And to give you a bit more sense of this characteristic of frailty, I would like to go through this figure. And we were pleased that we could publish it, in fact, in the Lancet to make this frailty notion known to a wide audience. And I very much love this figure because it's so easy. And here you can see this green line, which is in fact representing patients that are not frail. And when they're not frail, when there's a minor stressor, such as a urinary tract infection, people lose a bit of their functional performance, but recover rather quickly. And after recovery, they have the same level of performance as before their urinary tract infection. And these minor stresses, of course, may also be minor surgical treatments. But when we go to a frail person, a frail older person, there's a big loss of functional performance. And it's going in the state of dependency. And what is very important also is that there is slowing down of recovery. So the recovery is not so quickly, and that's a basic characteristic in many biological systems. And last but not least, the functional repair is not complete. There's a rest of functional decline. So this characteristic you often recognize in clinics. I'm sure about it. But the only thing which is not so easy is to get these people really validly out of each other, to identify them early. And why is this important? Well, I would like to take you for a trip to the Monument Valley. People from the States, of course, know it, and many others probably also. It's fantastic. Monument Valley, it's fantastic to walk there. But you also have these kind of rocks over there. So it also seems a bit dangerous to walk there. And this is my metaphor of, let's say, frailty in nature. Now, how do surgeons walk along these blocks, these rocks? Do they go just rather slowly and looking all around and making pictures? Or are they going there quickly? Who's for slow walking here? Nobody. Only a few. Well, there are some for slow walking. And then the quick walkers, that's more or less a majority, but a bit hesitating also. Well, to me, that's a metaphor of a surgical procedure. And it's not always certain what is best, slow or quick. Because these rocks, as I was told, they fall apart every 15 years. So once in 15 years, and you never know whether you are just heading towards this falling down. And that's also in patients. There's a lot of coincidence, there's a lot of chance, but they may, in fact, have a sudden decline and all systems deteriorate. So what I would like to propose is that you very determinedly decide whether you go for slow walking in frail patients, follow the guideline, do the high tech you have met just recently, or that you do a very quick repair, a quick and dirty repair, which may be the best in very frail patients. But to my experience, that's often a very difficult decision. It's very difficult for surgeons to go for quick and dirty repair, while the physiological state of these patients may require not a long stressor in a surgical theater. So that's something maybe this day also will give some light on, and it's, I think, an important, a crucial thing to teach this decision point. Where do you want to go? Slow walking or quick return? And that's everywhere in surgery, it's everywhere in surgical oncology, and it's about decision making. And there, Harry and I will try to make up a project on surgical decision making, also based on these perspectives and also on the perspective of what, in fact, does a patient want most? What is preferenced? What is the priority of a treatment? And there we also need some instruments, and we here from the geriatric department in Radboud, we propose the Easy Care instrument to have an assessment of all domains that are relevant for an elderly person, and then try to come to the priority of a treatment and assess and take this goal also in the choice for the very technical and concrete surgical procedure. And does it help? Well, we think it helps, and we also have some preliminary data that you in fact gain added value, you gain functional performance after discharge. So here we presented the GIDS project in 4 departments of the Radboud University Hospital, and it's consisting of screening on frailty, of treating risk factors, on a medical review and on activation in physical sense, in psychological sense, and we guide discharge. That's what we do. And in a quick conclusion about results, we saw that though the patients were getting more ill, it's just a before-after study. I must admit this. We could not randomize this complex intervention. But before-after, in a group which was more severely ill, we did not get more complications. So that's a moderate win, you might say. But a more important win is that the functional performance in 3 months improved, which is in line with the caregiver burden that decreased 3 months after discharge. So that's where all the people do it for. That's where they want your treatment for. It's not about the treatment itself, of course. So that's a good result, and that's one of the reasons also that this hospital deserved, in fact, the statement, the label of a senior-friendly hospital. And that's something we are very glad for. And that's something also which, in fact, is a label, is a mark of surgery over here, senior-friendly surgery. That's, in fact, something to go for. That's a very valid aim in this time period of aging societies. But we still have to do something for it. We have to teach, we have to learn how to do it and do it together. geriatrics and surgery, and as far as it goes, you should do it yourself. So coming to an end of my talk, how to do this training? Well, of course, use all kind of innovations. Use innovations, and here's an innovation we try to implement in the training of residents. It's about geriatrics. It's a serious game in which the students are challenged to make this decision-making. In their modern atmosphere of serious gaming, they are challenged to make decisions, important decisions for frail elderly people. And this would be excellently fitting also the training of surgeons. So, finally, where is it all about? This silver tsunami is not landed yet in surgery, I think. This is often still the smell of the place. This is what we like most, probably. The smell of the place, young patients, just one disease, doing just a fine job and really getting admiration afterwards of these young ladies. That is what we dream of when we start medicine. But it's not the smell of our place anymore. This is the smell of the place. This is where you have to go for. And this is where we have to try to make, in fact, our theaters Mrs. Franson proof, comorbidity proof, frailty proof. That's what we have to try to do together in surgery, in geriatrics, and all over the place, I think. And of course, we have great leaders there. We need great leaders. We need inspirers. We need people with guts. And that's where there's a lot of in surgery. So I'm not afraid. There's a lot of guts in surgery. And there's a lot of guts also in teaching. So that's about Harry also. And there I would like to end. Really, it's about wishing Harry a lot of silver teaching pleasure, of course. It's about the silver tsunami. People often turn gray, but sometimes people also get bald when they get older. So it's not so easy to tell the age of Harry, but I would predict him a long future happily in teaching to 2020 and far beyond. So thank you very much.